It's a little different for everyone, but it's a dissociative. So it feels like an out-of-body experience. And you feel like you are transported or teleported somewhere. And for some people, it feels, not for everyone, for some people, it feels like near-death experience where you can sort of like, you lift up from your body and you can see your body beneath you. That's not the case for everyone. For some people, but it is dissociative, and so there's this kind of traveling component. And because ketamine works on the NMDA receptors in the brain, it affects things like memory and learning. It increases neuroplasticity. It allows your brain to sort of reset in a way.
Welcome to the Future of Psychiatry podcast, where we explore novel technology and new innovations in mental health. I'm your host, Dr. Bassi, an addiction physician and biomedical engineer. Today, we are with Sherry Rais, who is the CEO of Anthea. Anthea is a third-party administrator of health insurance benefits with a mission to provide safe and affordable psychedelic-assisted therapies, starting with ketamine therapy. Through these benefits, other companies can cover this new and innovative treatment for their employees and families, leading to lower medical costs and a more engaged workforce. Anthea's services currently cover ketamine-based therapies and will also include MDMA and psilocybin-based therapies as well as they become approved. Sherry believes in living and working in alignment with purpose and is currently focused on expanding access to psychedelic-assisted therapy to alleviate human suffering. Welcome, Sherry.
Thank you for having me.
So I know recently Anthea announced the nationwide availability of ketamine-assisted therapy as an employee benefit. I'm sure a lot of listeners probably never heard of that, heard of their employers offering. How did you become interested in this, and why do you feel it's so important for employees to offer that to their employees?
Yeah. So how I became interested in this is perhaps a longer story that I will try to condense. I spent about a decade in humanitarian international development work, 10 years consulting to the UN and the World Bank. In those 10 years, I worked primarily on poverty reduction and worked on the ground in the field full time and ended up designing and implementing poverty reduction programs at the national level in 37 countries. Through that experience, and just for context, I worked in countries like Afghanistan, Yemen, Syria, so very resource-constrained environment. And through that experience, I saw firsthand the effects of intergenerational poverty and community, the effects of war and conflict, mental health, and really saw that if my mission was to reduce poverty, I saw that we can't fully address poverty without addressing mental health. So I began to look for solutions to address mental health issues and was really surprised. I'm from Canada, studied in Canada and England, and I was working in countries all over Africa and Asia and South America. I assumed that back in the West, we would have solutions to address mental health issues, and I simply had to find a way to implement them in these resource-constrained environments. I was really surprised and disheartened to see the data that a lot of the ways we are currently treating mental health don't work for most people. So they work for some. Not to say that we're not doing anything right, but there's a lot of room for improvement, and the data tells us that. I then stumbled upon what was happening in the psychedelic space, and I started to read the data coming up, clinical trials, reputable organizations and research coming top universities showing the potential benefits of psychedelic assisted therapy. And the more I read, the more intrigued I became. I wanted to find a way for people to have access to these medicines, as currently they are not covered. Some of them are FDA approved, so that's a huge issue. The ones that are FDA approved, like ketamine therapy, are covered by major insurance carriers. Getting them offered more resource-constrained environments like the countries I was working in is difficult to do through agencies like the UN and the World Bank if there isn't a model to follow. So if no other country has really done this before, it's hard to sort of pitch in a more resource-constrained environment. That's a long way of saying that's what led me to create Anthea along with my co-founders. But it was this idea of helping people get access to these innovative evidence-based treatments in a world where so many people are suffering and not getting the treatment they need, or are trying medication and coming off medication because it helps them.
Yeah, and I know Anthea is offering nationwide availability of ketamine-assisted therapy as an employee benefit, so employers can check that off alongside dental and vision insurance. And we know the benefits of ketamine and treating depression and PTSD. And you mentioned that employers who opt in can essentially reduce costs of overall medical care for those patients. And how did you analyze that data to come to that conclusion? I think that's obviously a very important one for employers to consider.
Yeah, so there are direct and indirect costs of mental health on employers, so thus direct and indirect savings. For employers who are self-funded, so they are paying medical costs of their employees, there's a direct 3.5 to 4x ROI on offering ketamine therapy to their employee population, because the cost of a complete course of ketamine therapy can range 4 to, let's do a large range, 4 to 8, or even go to a higher range, $4,000 to $10,000 a year for a complete course. You don't repeat this treatment year after year after year. You do it once, and most people are actually cured and don't need to continue ketamine therapy. And as a result, they come up with their SSRIs. SSRIs and talk therapy run employers a bill $15,000 to $25,000 a year, and that cost is repeated year after year after year. So there's the direct savings on the cost of medication and therapy versus ketamine therapy, and then there's the indirect cost of offering something that's going to get to the root cause of people's illness. And for some people who are treatment resistant, it's helping them in ways that traditional approaches just cannot help them because they've tried those approaches and they failed. You're getting to a more engaged workforce, more productivity, probably better retention, sick days, less disability claims. So those are sort of the indirect costs. And then I should have also mentioned, kind of in between direct and indirect costs, there's something we call the multiplier effect, which I'm sure you're familiar with, which is the cost treating someone for, let's call it diabetes or cancer, when they have a mental health condition, can be significantly higher when they have the mental health condition versus when they don't. So by treating the mental health condition, now their cost of cancer treatment or diabetes treatment or number of ER visits will also go down.
Why do you think that happens for individuals who struggle with mental illness? Are they having more appointments or are somaticizing their illness into other parts of their body that aren't actually unhealthy?
I think it's a combination. There's the things you've mentioned, and also when you have a serious mental health condition, it makes it harder for you to follow your prescribed medication and regimen and whatever the doctor asks you to do for your diabetes care management or your weight management. When you're struggling with a mental health issue, it's hard to follow instructions as well. So that's a huge issue. And then the anxiety, like living with anxiety when you have a mental health issue, also leads to just more hospital visits, sometimes even necessary ER visits, quotation marks on the word necessary, but added visits to the ER due to anxiety and stress. Then there's the effect of stress on the body.
Right. Yeah. Hyperinflammation and cytokines and all that stuff. So obviously there's a traction there from a cost savings perspective for the employer. And then I think a lot of patients and individuals are interested in it. Is their level of interest high enough where they want this on their insurance policy? Or like, how do you take that cost savings and translate it to, yeah, this is also good for all of your employees to have and be able to consider if they wanted to?
Yeah, so that's what we're essentially trying to create with Anthea by offering this as sort of an ancillary benefit to large employee populations. We want it to be as normal as employees wanting and needing dental and vision coverage. They should have coverage for psychedelic healthcare as well. And there is definitely a lot of interest. Like if you look at the numbers, 1 billion people in the world are suffering from a mental health condition right now. In the US, 1 in 2 people will experience a mental health issue at some point in their life. And then if we extend that to, say, 1 in 2 people will experience a mental health issue, but then everyone is really affected if you think of family members, friends, people that you care about that are affected by this. And the instance of treatment-resistant conditions, like before I got into this space and working in Anthea, I had no idea that 30 to 50% of people with depression are actually treatment-resistant. And so there is a huge demand for options like ketamine-assisted therapy, which has evidence to work on treatment-resistant populations because it gives people the sense of hope that they sort of have lost.
Sounds like there's a need, there's a cost savings. Why do you think more insurance plans don't include it? Or is there like a lot of challenges that you ran into that are preventing those insurers from covering it?
I think and hope they eventually will. Large insurance companies tend to work with a lot more red tape and tend to work a little bit slower. The idea is that through Anthea, like as we grow and like you mentioned, we have nationwide access and build our provider network and build our customer base and have more data to show patient outcomes and benefits, the insurance carriers spend more time paying attention. I think it's still a very nascent industry. And while there is clinical evidence, a lot of clinical evidence benefit of ketamine therapy, probably insurance carriers to see more evidence. And then, of course, not to sound pessimistic, there is a case of this may lead to them making less money because, in essence, people will spend less on SSRIs and other types of medications for health issues. So there's that kind of push-pull on motives there. But yes, I do think large insurance carriers will cover this. I think it's a matter of time. And really, Anthea is here to fill that gap. So let's say it takes 2 to 3 years for large insurance carriers to really build out the policies, the standards of care, the provider network in this space. In the meantime, there's millions of people suffering. And hoping we can help those people.
It's so cool to think about. As a clinician, I don't really get the ability to talk to somebody who has the information and knowledge of how giving somebody a fairly expensive type of treatment can lead to more savings on a population level. From an outsider's perspective, it does seem hard to believe that spending $10,000 on ketamine treatment will necessarily lead you to more than $10,000 in savings, maybe in productivity, an improved or reduction in medical workups. But I guess if that saves one ER visit, or probably one ER visit is about 10,000, right? Then I guess it pays for itself in savings right there.
Even if it gets you off SSRIs, because SSRIs alone, if you're taking them every day, it's about 10,000 a year.
Oh, is it?
Yeah.
For Mybrid, perhaps, for Lazodone, some generics, I don't know, do they cost the insurance company that?
Some generics might be a little bit cheaper, but if you look at the 2-year cost, then you're definitely saving it. You're definitely seeing savings because the idea is you're no longer taking the SSRIs.
Yeah, and that's a win, even regardless of cost. What is Anthea's process in getting the approval for the employee? Like, do you need to do pre-authorization or anything like that?
So we do have pre-authorization, and right now we cover 6 different indications for ketamine-assisted therapy based on what we've seen in the literature. You mentioned some like PTSD, depression, social adjustment disorder. To some people's surprise, actually, ketamine-assisted therapy can be very effective for addiction, like alcohol abuse disorder as well. So yeah, we do require pre-authorization, 6 indications that are covered. But then after that, essentially, patient works directly with the provider according to their in-network provider. So according to our standards of care, medical policies, complete the treatment. I don't know if you saw, but we've had really tremendous results, like with our pilot or proof of concept, Dr. Bronner's, the soap company. We saw that in a 1-year follow-up, patients with PTSD, for example, had an 87% reduction in their symptoms, which is really like unheard of. Similarly, we saw a 67% reduction in depression symptoms and 65% reduction in anxiety symptoms. And this is like, again, at 1 year.
That's pretty incredible. And how was that, like a survey that got sent? Do you remember the standardization or like the standardized test that was collected for those? Is a PHQ-9 that gets sent to them afterwards?
PHQ-9, now you're catching me because I'm not a clinician, but PHQ-9, GAD-7, and PCL-5.
Got it. Yeah, that makes sense.
The standard, I guess, ones for PTSD, depression.
That's pretty incredible. What would a person expect in treatment? I mean, for individuals who aren't familiar with ketamine-assisted therapy, can you give a little bit background? I'm sure a lot of people are a little bit scared and fearful of ketamine. They don't really know who to believe about it.
Yeah. So ketamine has been used as an anesthetic for almost 60 years. It's on the World Health Organization's list of essential medicines. As a result, we have like data, even global data and data in the US of its safety for over 5 decades. When used as a mental health treatment, we are using it in sub-anesthetic level. So it's a much smaller dosage. As an anesthetic, it's even sometimes prescribed to children as an anesthetic. So it's medicine we do feel comfortable prescribing to children as an anesthetic. And it's approved nationwide in the US and pretty much anywhere in the world. No place where ketamine is approved. And as a mental health treatment, it starts with person assessment. So patient would approach. If they're an Anthea member, they would head in our portal, log in, find a provider that's in network, and do both a psychological and medical assessment to determine if they're a good candidate for ketamine-assisted therapy. And that's when they'll do the pre-authorization with us, assuming they approve. They then start what is called preparation. So it's not a case of someone I want to try some ketamine, and they go to the clinic and they get some ketamine and they go. This all happens in 2 days. No. So it starts with preparation, and that's working with a licensed therapist. It could be 1 to 3 sessions of preparation, separate occasions, of really outlining what are your intentions, what are your goals, why are you trying to do this? A lot like therapy sessions, but very intentional therapy sessions on what you're hoping to achieve through the sessions. And probably there's an education component there too, patient the detail. And then you will do what's called the medication session. So depending on what the provider thinks is the best course of treatment, it could be anywhere from 1 to 6 sessions of ketamine. And this ketamine would be administered. There's different modes of administration. It can be an IV or IM, or it can be administered orally, like through a lozenge. And you would, if you're doing this in clinic, you would take the ketamine. You would have somebody there with you, like a licensed health professional there with you. And to sort of speak, I think you also want to know, like, what does this feel like?
Right. The $1 million question. How am I going to feel?
It's a little different for everyone, but it's a dissociative. So it feels like an out-of-body experience. You feel like you are transported or teleported somewhere. And for some people, it feels, not for everyone, for some people, it feels like a near-death experience where you can sort of like, you lift up from your body and you can see your body beneath you. That's not the case for everyone. for some people, but it is dissociative. And so there's this kind of traveling component. And because ketamine works on the NMDA receptors in the brain, it affects things like memory and learning. It increases neuroplasticity. It allows your brain to sort of reset in a way. And there are two options. In some cases, while you are under the influence of ketamine, you will also be talking to the therapist and they will be listening, and you'll be talking about what you're experiencing and what you're going through and what you're processing. Perhaps it's past traumas, perhaps you're revisiting a childhood memory. So you may talk to your therapist while you're under the influence. There is also a scenario in which you don't do that. You experience the ketamine, there's somebody there beside you to make sure you're okay, but you're not really talking to anyone for that. It's a duration of 60 to 90 minutes, so you're not talking to anyone. And you do the therapy after, like in the next day or so, where you kind of process everything you went through. So there are two ways, and that's kind of depending on what's best for the patient and what the provider's sort of style is as well. And then after those medication sessions, you do what's called integration. And integration is more therapy, more speaking to your therapist about kind of processing everything that you went through and sort of like cementing those new connections that were made in your brain due to the increased neuroplasticity. And the whole thing, let's say you did 6 treatments, it takes about 3 months. It could be less if you're doing less than 6 treatments, so 1 to 3 months. Hopefully that answers kind of what it feels like. Unlike MDMA-assisted therapy and psilocybin-assisted therapy, which are super powerful and transformative experiences, ketamine is also transformative, but ketamine is a shorter duration. So you can do ketamine therapy and go to work the next day. You could do ketamine therapy after work and still go to work the next day. So that also makes it a little bit more convenient. With psilocybin or MDMA-assisted therapy, by contrast, you probably want to decompress for 1 to 2 days afterwards, because the duration of the medication is like 6 to 8 hours.
Do you need to get a ride home after a ketamine session?
It's recommended, yes.
Gotcha. So it's almost like a procedure in a way, kind of like ECT or maybe actually TMS, they're allowed to drive home afterwards.
I think you're technically allowed to drive home as well with ketamine if you spend a certain amount of time just waiting in the clinic before you drive. So I think that's fine. But some of the minor side effects from ketamine-assisted therapy is like dizziness or a little bit of a headache. So you might prefer not to drive home. Depends on the person.
Obviously, all of these little factors are taken into consideration by patient, the cost and the convenience. And you mentioned it can help mitigate racial disparity in diagnosis and treatment of mental health conditions. And can you talk to us a little bit about that? In what ways have you found it to mitigate any racial disparities?
I don't believe I mentioned that, but
Sorry.
No problem. I think, to be very transparent, it is our hope that this is something we'll be able to achieve, because the way we are building our network is we're trying to build it across the country. We now have like 135 clinicians nationwide serving in underserved communities and different zip codes, regardless of like socioeconomic status. So we're being very mindful of the providers we are bringing in network. We don't actually have data to show that we're mitigating these racial disparities yet. It's very much a hope and aspiration. And hopefully I can come to you a year from now with an update and tell you what we've achieved, as we're still super early. It's, I think, too soon to say that. I know we are super thankful to my team building our provider network very consciously, looking at languages spoken, making sure that people feel comfortable with the providers in our network.
I appreciate that answer. I think whenever we open up access to care and reduce cost to care, it's opening up a treatment modality that was typically only for very wealthy individuals. And now any individual from Dr. Bronner's, for example, or an employer can now access that. So you mentioned that clinicians will have to become in network, right? Is there coverage for out of network? Or what if somebody is in maybe a smaller city working from home for one of these employers? What's that network like? And if it's still growing, can somebody go to some psychiatrist who maybe they're more comfortable with, but isn't in network yet?
So we have different options. One, we're very much constantly growing our network. We had 1 clinician at the beginning of this year, January this year. And now, like I said, we have over 100. We're really trying to grow it carefully, intentionally, but quickly as well, across different zip codes. Because we are a startup, we have a very close, hopefully we can maintain this, but we right now have like a close relationship with all of our customers. We have just over 10 customers to date, in addition to Dr. Bronner's. And so because of that relationship, our customers, they give us, an employee roster, and they'll tell us, we actually ask, like, do you have employees that are outside of the metropolitan area? They're working remotely. We've had a few cases recently, like in Arizona, somewhere remote, where we've had employees. And then we will go and take the time to look for a provider that's in that area. There are actually close to, I think, 1,000 ketamine providers in the country now. So it's a very quickly growing industry. We're being selective of who we bring in network because we want to ensure safety. But yes, we'll definitely work with employers to try to accommodate where we have remote employees. Then it is kind of up to the employer when we do the benefit design with them on how to handle out-of-network cases. Similar to when an employer is picking their dental or vision, they have a few options when picking that plan. Like, do I want to cover 75% or 100% or 80% or have a copay? And what do I do with out-of-network dentists if I was picking dental plans? So similar to that, we have that conversation with employers as well, and it's included in our benefit design. So it sort of depends on the employer. Some employers have decided that they will, like, say Dr. Bronner said, we will cover out-of-network providers because we want to make sure people have access to this treatment. And other employers will say no, and we won't cover it. And other employers will say, we'll cover it. Let us know what the cost might be. So maybe it's conditional coverage. And then finally, sorry, again, a long answer. This is such an important question when it comes to access. We have included just recently over the summer in our medical policies the inclusion of at-home options for ketamine therapy, which means that anywhere in the country, people could receive ketamine in the convenience of their home, could do a virtual telehealth session with their therapist, and they could do the ketamine therapy. So that is an option as well, that one is a lot more cost effective, two, more importantly, helps solve this problem of geographic access.
Is there a higher degree of scrutiny of the policies or protocols that they have in place for at home?
There's a higher degree of policies that we impose on the at-home providers we work with. So how they work with other patients that they have that don't come through Anthea is really up to them. I mean, we of course look at their policies and make sure that they make sense, but then we have some added protection and safety mitigation measures, like for example, limiting the amount of doses of ketamine that can be sent to someone in mail. Perhaps there are some at-home ketamine providers that might send you 6, but we will say, no, we want to limit it to 1 to 2 doses in mail so that there's use.
In light of recent news with Matthew Perry and people finding out that ketamine had some interaction or some role to play, I think when instances like that happen, it can cause kind of a shift of public sentiment and concern about it. And understandably, people tend to jump to conclusions before having all the facts about something that is safe. There's always other factors at play that we probably don't know about in those types of cases or instances. But I think just like in person, there's also, a wide variety of safety protocols for companies that administer at-home care. So it doesn't equate to saying like this is not necessarily as safe, because it obviously depends on the company and how closely aligned the therapist is with that patient and monitoring them.
Exactly. Like another example of something we require for at-home therapy is the presence of a sitter. So this means if I'm going to do ketamine virtually at home, my therapist virtually, I'm still required to have someone physically present beside me in the room to make sure that, okay, I'm required to prove that this person is there. It's just an example of another measure to ensure safety.
What types of challenges, maybe from either a business perspective, public health perspective, clinical perspective, like what is on your plate that you feel is a challenge that you need to overcome in the short or near term?
One, there's still stigma. So I'm like, on the one hand, very excited about people's openness and the shift that is happening around psychedelic therapy and ketamine therapy, like even that I'm here. Our podcast, which is not a psychedelic specific podcast, it's a psychiatry podcast. So there's a shift happening and I'm grateful for that. And yet in my day-to-day, especially when talking to potential employers, there is definitely still a stigma around psychedelics. And I tend to trapped in this bubble because I'm in the psychedelics industry and I think, oh, everyone knows about psychedelics and their benefits and how amazing they are and how they can change your life. And then I, go to an HR conference and I'm like, oh, wait, no, that's not true. Not everybody. So there's still this stigma. And I think a lot of that stigma comes from connections to these medicines and recreational use. So it's very common when I'm talking about psilocybin-assisted therapy for someone to interrupt me and say, oh, you mean like shrooms? What I did in college? And I'm like, well, not exactly. Like, yes and no. So it's hard, especially if someone did have a recreational experience, it's hard for them to now think of this as a medicine. And I'm being very transparent and open and honest with you. I get it. If someone told me that vodka was a medicine, I would struggle to shift my mindset around vodka or alcohol, right? So there's that stigma that is a challenge and we're making progress, but it's still difficult. And you already mentioned the tragic loss of Matthew Perry, but then the media and people's sort of jumping to conclusions around what happened is a current, present, more acute challenge. And then there is the fact that since COVID, a lot, actually, I think 76% of employers with more than 100 employees in America invested in some sort of mental health benefit, additional benefit, like an EAP, or if they're a smaller company, it might have just been meditation classes or different mental health zones that are out there. And of course, They invested in something recently. It was a big thing in their company to now offer this to their employees, whatever they offered since COVID. But in effect, the data shows that the utilization of these new mental health add-ons is fairly low, like 7 to 9%. And especially after the first year. And not like, again, we're just giving people better access to the same things we've had that are not necessarily working for everyone. So it's great if I have a better way to access a therapist to talk to. I'm not discounting that. That's great that I have an easy way through an app to talk to a therapist because that's really important. But if I have treatment-resistant depression and I've been talking to a therapist for 10 years and it hasn't helped me, I might need something else, and this add-on won't help me with that. So this is a challenge because now when we're talking to employers and we are definitely presenting something new and something different, something unique, there's the business side of things of, well, we just invested in this like last year, so we can't invest in another thing, even if it's more effective. That's my biggest challenge. If you have a solution for this, I'm all ears.
That part about the 7 to 9% is really interesting. What percent, if there was like perfect utilization among individuals who needed it, what percentage do you think it would be? Like 20 to 30%? Like, what is our gap here that we need to try to get it to?
I think just based on data, like 25% are probably suffering from a serious mental health thing. So 25%.
It's partially, maybe they don't know about it, so there's a little bit of education piece. Maybe it's time.
There's cultural stuff too, still around mental health.
Absolutely, which is harder to overcome based on a person's initial preconceptions about it, or they don't necessarily see or know about the potential benefits of them getting help necessarily. They might see it as kind of a hindrance to, living their life in a way based on stigma, mental health clinicians or whatnot, or maybe they had a bad experience before in the past with therapy or seeing another clinician who didn't listen to them. Why would I want to repeat that experience with somebody who wasn't really listening or understanding me? So I think like given the fact that it is multifactorial about why people are not utilizing it, it requires a multifactorial type of solution really to go about doing something like that and increasing utilization to allow both the employers and the employees to see a benefit for getting that utilization higher in order to have better savings and better quality of life downstream from that. So that what is like $1 of prevention equal to in terms of treatment in the healthcare industry? At least a few dollars worth of savings. But it's hard. We have a cognitive bias against outright spending initially when we don't know of the certainty of what that's going to lead to in savings down the road.
This is why, not to promote my own company too much, but in our model at Anthea, we only charge on utilization. So we don't charge per employee per month. If nobody uses this, it doesn't cost the employer anything. And I think that we did that because we wanted to kind of sort of combat this stigma that exists of investing in something. There really isn't an investment unless it gets used.
Was that a difficult decision to make it that model? Because that's not a typical model compared to United Healthcare and Aetna, right?
Right. Was it difficult? No. Was it wise from a business perspective? To be determined. I think it was the right decision to make, at least for now. When we have a lot more data on what I just shared with you about Bronner's data, when we have more data on patient outcomes and we can make the use case of like, okay, with certainty, this is like definitely going to save you. We can do all the economic analysis on how much this is going to save employers. We might change that model. But right now, the real focus for us is not on the business's economic success. Like that will be important, but we're actually structured as a public benefit corporation. So our priority is first to the public and access into helping people heal.
As an employer, it does make a lot of sense if it leads to happier workplace environments and more productive employees. How does an employer, maybe I don't have an MBA background, so maybe I should just look this up online or something, but how do I measure productivity of employees other than just like number of patients seen? Or, I mean, even that metric can be pretty variable like throughout the year. So how do you recommend that employer do that? Or is that just left up to like the HR team to monitor over time?
So that's a really good question. And when you put this podcast up, if your audience puts things in the comments on ideas on this, like I'm going to be very excited to hear about it. There are different things that you can use as sort of measures. One, not so much directly on productivity, but on like employee satisfaction is retention. Like how many employees per year are leaving the company as a percentage.
Is there an industry standard? I don't actually know. What is the industry standard?
Yeah, it depends on the size of the industry, but as like a very like aspirational thing, you should have like 95% retention, and every HR person listening to this is going to get mad at I'm just putting a blanket statement out there because it does depend on industry and the size of the company. At certain stages, like very large companies will have more retention issues perhaps than smaller companies, but an aspirational goal is 95%. There are other measures that are important for employers, like employee engagement. There's different ways of doing this, but I think the leading survey is called the Gallup 12. Doing this for decades and decades and worked with hundreds of thousands of employers, but this is a survey to measure how engaged employees are. There's 12 questions on that survey, and some of them sort of cover how productive I feel at work. Not all of them. They're also about, like, do I get enough positive feedback? Do I have a friend at work I can talk to? There's a variety of questions, but overall engagement is important. And then you're really measuring productivity in your company's like performance evaluations and 360 feedback. You're doing them annually or biannually. If employees are, not to make it so transactional, but if employees are hitting their individual goals versus if they're not, that's progress.
Awesome. Yeah, that makes a whole lot of sense. And it gives people some inspiration as well for what to shoot for. It's definitely, it's a win-win situation for both the employer and the employee. If the employer's happy and the employee's happy, I feel like that's what everyone's trying to strive for at the end of the day. Well, Sherry, it is awesome speaking with you about Anthea, and I think you guys all are doing such great things there in trying to move the needle and making progress in the health insurance industry, which is a challenging one, obviously, and the psychedelic industry, which is another challenging industry fraught with a lot of stigma attached to it. If everything works well and works to plan, I think it has such great potential here, and I think that makes me excited for you and your mission and in trying to get equitable access for more employers and more employees to psychedelic-assisted therapy. So I really appreciate you coming on and talking to us today. Give you opportunity to have a last word with our audience, if you'd like.
Thank you so much for having me. I really enjoyed this. As a last word, I would say if people have more questions or want to learn more, they can reach out. They can go to the Anthea website. They can email us at info@anthea.com or email me directly at sherry@anthea.com. Also wanted to say that even people don't have questions from a business perspective on becoming an employer, but just are more curious from a personal perspective on the benefits about psychedelic therapy or ketamine therapy, or they have a friend or family member that might be interested, very happy. And it actually brings me joy to answer these types of questions. So please feel free to ask and reach out. And then I guess finally, we're entering the holiday period, which I know can sometimes trigger people's anxiety and emotions, especially with family members. I don't know if this podcast will be released before or after the holiday period, but in any event, just really encouraging people to just, be kind to yourselves, be kind to the people around you, and take a few seconds to ask the people around you how they're doing.
That's really well put. And we'll put your social media handles in the show notes as well for people to find you all. It probably come out in February. So I'm trying to think about when the next holiday is. Maybe Valentine's is triggering for people, but it's probably going to be pushed out before Valentine's. But I appreciate you so much. And thank you for your time today.
Thank you so much.
That's it for this episode. I'd appreciate it if you please like and share this podcast with your colleagues. It'd be especially helpful for us. If you'd like, please leave us a rating on your favorite podcatcher. If you're a clinician, I developed a course on how to start a private practice. And for patients, I've also developed a course on acceptance and commitment therapy and cognitive behavioral-based therapy lessons for treating and helping anxiety. You can find all these on our website as well as the show notes and resources for each episode. Thank you so much, and I'll see you in the next episode.